see your name, you can put your name. Rana, you want to get started?
All right, so we're very excited to for this journal club today. So thank you, Neil, for being the first one to present. So Neil Jacob is currently a biochemical fellow at Mount Sinai, and he's going to be presenting the long-term efficacy and tolerability of Pegzilarginase for Arginase 1 deficiency. And these are results of 2 international multi-center open label extension studies. So you could start.
Just share my screen here. And you guys can see the full screen?
Yes, we do.
Excellent. Okay. So thank you so much for the introduction. Like what Rana said, my name is Neil Jacob, and I'm a medical biochemical fellow at the Icahn School of Medicine in New York City. So yeah, I found very interesting Pegzilarginase, and for the treatment of Arginase deficiency. And there's been a handful of trials that have looked at Arginase at Pegzilarginase, but this study has specifically looked at the long-term efficacy of 2 different trials. So I just want to say that I am co-investigator for a Pegzilarginase trial at Mount Sinai, but I did not work on any of these studies. So I'm going to briefly talk about the urea cycle. I know everybody here is pretty familiar with that, but I just want to stay on the basics and then kind of go from there and talk about Arginase deficiency. I'll also talk about the 2 prior studies very briefly and then kind of go into the results of this long-term study. So Arginase deficiency is an autosomal recessive urea cycle defect. Looking at the urea cycle here, you can see that I can start in the mitochondria where you have bicarb and ammonia come together to form carbamoyl phosphate bicarbamoyl phosphate synthase. And then that binds to ornithine with ornithine transcarbamylase and turns into citrulline. And then citrulline is transported out of the mitochondria into the intercellular space, and aspartate joins that with arginate succinate synthetase 1, and then that turns into arginosuccinate. And that is broken down by arginosuccinate lyase, and that breaks down into fumarate and arginine. And then arginine is further degraded into urea, which goes and is excreted in the urine, and then turns into, and then as well as ornithine. And then that goes into the mitochondria and kind of goes into the cycle. And so arginase deficiency is a problem with the breakdown of arginine. This is a distal urea cycle defect. It's not. It doesn't lead to like as much of a severe hyperammonemia that you may see in OTC deficiency, but it does lead to hyperarginemia, and chronically that can lead to spasticity. Typically see that in the lower and the upper extremities. You also see developmental delay, and you can also see liver dysfunction with coagulopathy. The standard of care is protein restriction and amino acid supplementation. But you may have a baseline hyperammonemia that may require nitrogen scavengers. And so Pegzilarginase cleaves the arginine in the extracellular space up here. This is a recombinant pegylated enzyme. It has better activity with a lower Km than the native enzyme, and it's more stable than the native enzyme too, because its half-life is extended by that pegylation that it has. This medication is given subcutaneously and intravenously every week, and you typically start at a dose of 1.1 mg per kg per week. So looking at the original studies first, and then we'll kind of go into the orange section, which this is where the study, this paper kind of looks at. So the study 101A was a single-arm multinational study, and it was performed at 9 different centers. And they started the study with an ascending dose every 2 weeks, and at 8 until they kind of met the goal arginine levels, and then they followed that dose for 8 weeks. The inclusion criteria included either a molecular or a biochemical diagnosis of arginase deficiency, and that was defined as 200 micromoles per liter of arginine. And they included individuals that were 2 years or older. The exclusion criteria included severe uncontrolled hyperammonemia or any hypersensitivity to the PEG part of the enzyme. And so individuals that were able to complete the 101A trial were eligible for the 102A trial part of the trial. The first 12 weeks of the open label extension showed some really significant improvements in mobility for these individuals. So we'll be talking with the 12 weeks and on for the open label extension. Going to the PEACE trial, this was a randomized double-blind placebo-controlled study that then went into an open label extension as well, and that was also multinational at 19 different centers. And this consisted of 2 different groups that were randomized from a 2-to-1, where they had individuals that were started on Pegzilarginase and then continued on Pegzilarginase, or the other cohort, which started on placebo and then went to Pegzilarginase. And so they were called, respectively, Pegzilarginase, or placebo Pegzilarginase. The inclusion criteria was very similar, where they had to have a molecular or a biochemical diagnosis. However, their definition of a biochemical diagnosis was greater than 250 micromoles per liter of arginine, plasma arginine. And these were individuals, again, that were 2 years or older. However, they were a little bit more strict with a baseline deficit. They had to have a baseline deficit and one kind of clinical assessment. They also excluded anybody who had severe motor deficits, or if they were receiving botulinum treatment for spasticity, or they had any prior exposure to Pegzilarginase. And the initial results from the long-term extension showed really great success after the additional 24 weeks in the clinical and in lower plasma arginine, as well as clinically meaningful improvement in the functional mobility. So I just have this slide just to show the number of cohorts in each group. So study 101A started with 16 individuals. 2 individuals were left the trial, and then 14 individuals entered the 102A trial. 1 individual left, and there was a total of 13 by the end of the trial of 102A. In the PEACE trial, 32 individuals originally were enrolled. And again, as I mentioned, there were a 2-to-1 randomization from the Pegzilarginase to the placebo. 1 individual left, and so the total at the end was 31. So that was a total altogether in this trial, in this long-term extension, was 44 participants. So I discussed the inclusion criteria and exclusion criteria for this, the cohort. And the treatment was basically whatever the drug started, whatever dose the trial ended at was the drug that the dose that they continued the treatment with. And that also included keeping that protein restriction the same, the amino acid supplementation, and if they're on nitrogen scavengers or other medications, they kept that the same. The biomarkers that they looked at on the long-term extension were plasma arginine and guanidal compounds. Briefly, guanidal compounds are basically they're byproducts of arginine metabolism, and it's suspected to lead that these metabolites lead to CNS toxicity and neuromotor symptoms. And then looking at the neuromotor and spasticity assessment, they used the 2-minute walk test for the PEACE trial and the 6-minute walk test with the 102A trial. And then they looked at something called the gross motor function measure, or the GMFM, and that was GMFMD and GMFME. The GMFMD included 13 different standing tasks. So it was basically non-movable, movable, like non-modal, mobile tasks. And that score ranged from 0 to 39. And then GMFME included 24 different tasks that revolved around walking, running, jumping, and that score ranged from 0 to 72. The lower the scores were the greater impairments in these individuals. They also looked at spasticity in these individuals, and they used the modified Ashworth scale, the MAS. That scale is on a spasticity level of 0 being normal to 4 being total rigidity. They also looked at hyperammonemic episodes, and this was described as an ammonia level greater than 100 micromoles with 1 or more hyperammonemic symptoms. And to make sure that all of these were clinically significant or clinically meaningful, they used the MCID, or the minimum clinically important difference. And they used a specific threshold for each criteria. And for the 6-minute walk test and the 2-minute and the 6-minute walk test, they used a 9% change or greater than 9% or more change. And the GMFMD and the GMFME, The change in the score really depended on the baseline spasticity when they entered the trial, and I'll briefly talk about that in a sec. And then they looked at safety events like adverse events and immunogenicity. So looking at the demographics, in the 102A, there was a really large proportion of females, so about 80% females to males. And then looking at the PEACE trial, there's about 60% males to 40% females. But overall, it was about a 50-50% in the total of the trial. The average age in the study 102A was 15.7 years. In the PEACE trial, it was 10.7 years. So around like early adolescence. Going to the like baseline features that these individuals had, this was out of 46 individuals, and 35% of them had a history of seizures. 67%, or that 31 individuals, had lower limb spasticity. And then half of them had a history of hyperammonemic episodes. And then going to the baseline treatment that they were on before starting the study, 89% were on nitrogen scavengers, and all of them were on a protein restriction. Now, I talked about the different baseline levels of spasticity, and they categorize these individuals with the gross motor function classification system. This classification system is usually used for individuals with cerebral palsy, and that kind of helps like describe their mobility and how kind of describe if they require equipment or not. And with this study, it goes from level 1 to level 5. And in this study, level 1 consisted of 46% of the population. And these are individuals who had really good mobility. They could run, they could jump, they could go upstairs, but they had decrease in speed and balance and coordination. And then level 2 consisted of individuals that had, needed a little assistance going upstairs, some difficulty with uneven surfaces or inclines, and they could still minimally jump and run. And that was 37% of the population of the cohort. And so the entire, like 83% of them had these level 1, level 2, lower end of the scoring system. And then level 3 included individuals who had some assistance, needed some assistance with walking. So they may have used a manual wheelchair. They needed some help with climbing stairs or railings. And that was about 4% of the cohort. And then lastly was level 4. And these were individuals who were severely limited in walking. But they did not have any level 5s. And these were individuals who could not sit, stand, or walk independently. Going into the results, the study 102A, the median treatment duration was about 207 weeks, while the PEACE trial included a median treatment of 94 weeks. And just looking at this graph here, starting with the arginine levels, the x-axis is obviously the weeks in the long-term extension. The y-axis is the arginine levels. In the 40 to 150 was the normal range for arginine levels that they considered. And you can see that the baseline, the arginine was close to about 200, a little bit more than 200, maybe 300 to 500. And you can see a significant decline in the arginine levels once starting the trial. In the 102A trial, all the individuals had levels under 200, with 56% of them in the normal range from the 40 to 115 micromoles. And then in their average, by week 192 was 118 micromoles per liter, so a little bit above the upper limit of normal. And then looking at the Pegzilarginase cohort, by 24 weeks, their average arginine levels was 88 micromoles per liter, and then by week 48 it was 82, and then by the end of that, by 96 weeks, it was 115. So again, a little bit above the at the upper limit of normal. And then going to the placebo Pegzilarginase cohort, they had, by 24 weeks, they had an average arginine level of 82. And then by 48 weeks, they had an average of 95, and they actually were in the normal range with an average of 100 micromoles per liter by 96 weeks. So it seemed like, the placebo Pegzilarginase trial had a little bit more control compared to the Pegzilarginase, but these were just averages. Going to the guanidal compounds, this study didn't go too much into the results of how these the results of the guanidal compounds. But when we came to guanidinoacetic acid, those normalized in all individuals. And then for the alpha in acetylarginine, those declined and nearly normalized. And then the arginic acid and the alpha keto delta guanidovaleric acid, those improved by half and from baseline, and then remained above normal though for those. And so going for the neuromotor outcomes, I mentioned the MCID threshold, and I mentioned for the 6-minute walk test and the 2-minute walk test, the MCID was the 9%. If there was any improvement above 9%, then it was considered clinically meaningful. And so for the 6-minute walk test, the average distance improved by 68 meters, and that was an average improvement of 19% from baseline. So up here so it was pretty clinically significant. And then in the PEACE trial, the Pegzilarginase cohort, the 2-minute walk test, the average distance of improvement was 16.5 meters, and then the average improvement was by 25% from baseline. I'm looking at this, and it didn't really show. It said the paper showed 25%, but this does not look like it's actually at the 25%. And then looking at the placebo Pegzilarginase, the 2-minute walk test showed improvement by 13.5 meters, which was 16% increase from baseline. So all of those were pretty significant clinically. And going from the GM-FMD, GM-FME category, and again, this had to do with standing tasks and mobility tasks, and all dependent on their baseline mobility scores. You can see that for each level, they had a different criteria for their MCID. So level 1 had a 2.4, while level 2 had a 3.3 that they had to meet for significance. And then level 3 had a 1.5 to show significance. And that was just for the GM-FMD for the 102A. And so for the 102A, that average improved by 2.7 for the D. And then by E, it had a improvement by an average of 3.7. So average, it did improve for the levels, for the E, it was for 2 and 3, but not for 1. And then looking at the PEACE trial, the Pegzilarginase, they had improvement by 4.3. And so you can see here that was above the level 2, level 1, and level 3 cutoff. And then for the E trial, the GM-FME for Pegzilarginase, that improved by 6 on average. So again, clinically meaningful for that. Going to the placebo Pegzilarginase, this gray bar right here, the GM-FMD, that improved by an average of 5.3. And then for the E, it improved by 11.3. So it improved quite significantly. 95% of the subjects met responder criteria, or they achieved a maximum score in at least one motor function. And then 33% showed improvement in all 3 motor domains. Now, I will say that the more response was seen in the GM-FCS levels 2 and 3, but this was most likely due to they had a more potential for a functional gain. For levels 4, these were excluded from MCID analysis because there wasn't a validated threshold that they could use. However, they did report that 2 subjects in the PEACE trial improved from level 3. And then also altogether in these cohorts, 4 participants improved in the GM-FCS level, with 1 going from level 2 to 4, so they worsened. And that was while they were in the placebo treatment, and then they improved to level 3 in the Pegzilarginase part of the treatment. So going to spasticity level, this again was measured by the modified Ashworth scale. Again, 0 was normal and 4 was total rigidity. In the 102A trial, everybody improved by weeks 96. And at 262 weeks, 4 subjects achieved a score of 0 in 1 or 2 affected groups. However, in the PEACE trial, not everybody improved. 84% or 16 out of the 19 individuals improved. 11% had no change, and then 1 individual worsened. And then 8 individuals in the entire trial, in this trial, or about 42%, had a score of 0. So it was pretty helpful in their spasticity. And then going to adverse events, all subjects had at least one treatment emergent adverse event, with most of them being mild or moderate. 6 had severe adverse events, with 2 of them requiring dose reduction. And in a 102A trial, the most common feature that they found was either an increased ammonia or a symptomatic hyperammonemia, and they had 10 individuals that had a hyperammonemic episode. This was usually, though, in the setting of infection or GI symptoms. And in the PEACE trial, the most common adverse event was an elevated transaminase, and this was about 5 out of 31 individuals, or 16%, had those elevated transaminases. And then they had a special category in the adverse events that they defined as adverse events of special interests. And that included individuals with hypersensitivity, an injection site reaction, or hyperammonemia. Nobody had an episode of hypersensitivity. I already discussed the hyperammonemia, though, but with injection site reaction, about 14% of individual total had an injection site reaction. And then going to immunogenicity, in study 102A, no one developed anti-drug antibodies. While in the PEACE trial, one subject that was in the placebo Pegzilarginase group had developed anti-drug antibodies, but those were transient and they resolved. So by the end of week 24, nobody had ADAs. So kind of in summary, looking at this paper, over the 262 weeks, there was a clinically meaningful improvement in the neuromotor function, mobility, and spasticity. Symptoms either stabilized or in some individuals actually improved. And they also showed improvement not only clinically, but also in the biochemical markers, as in plasma arginine and the guanidal compounds. And they also didn't go too much into this, but they also reported some improvement in the hyperammonemic episodes as well. And lastly, there was no immunogenicity in this study. And then kind of looking at the UCD guidelines, which they they want a arginine treatment goal of less than 200. And the baseline of these individuals' plasma arginine being around a little bit above 200 to 570 was kind of the range that they were at. It really shows that diet alone may not be the best treatment for arginase deficiency. And so seeing these changes kind of really shows that we can really meet that 200 level for the guidelines. And it is a pretty safe drug with some of the reactions. However, they did also report 13 hyperammonemic events during the trial, with 4 that they considered possibly or likely related to treatment. This was more common, though, in the placebo Pegzilarginase trial. And they weren't really sure exactly why some individuals had this hyperammonemic episode. They kind of explained it where, and it makes some sense, where the Pegzilarginase works extracellularly to break down that arginine into ornithine and urea. And that extracellular ornithine may not be able to get into the mitochondria to work properly in these situations. So that might have been the cause for the hyperammonemia. And then kind of looking at this treatment compared to the alternative therapy treatment option is liver transplant. I was just looking at one brief study. There's not that many studies on liver transplant, I will say, and arginase deficiency. But in a trial that looked at 11 individuals that had liver transplant, they did show improvement in all of them with their history with like an improvement in their seizures. And they showed only about a third of them, about 36% of that 11, that actually had normalization of their arginine levels. But given all of that, this really shows that this drug may show significant improvement with less adverse events and less risk that you can see in liver transplant. But going to the limitations, though, this study did not compare them to long-term control groups. So, they didn't look at a natural history of individuals and compare it to this group, these treated groups. And that might be kind of a study they can look for in the future when they have so much data. Another kind of limitation was that there was selection bias. They did only use individuals that were sick enough to be put onto therapy. They didn't look at individuals that were kind of in the normal range or unaffected or minimally affected. And then they just kind of looking at also just the natural history of arginase deficiency. You know, we have a kind of a biochemical rationale of the disease, and we have a clinical component to it, and we kind of understand the pathophysiology of how those how it works, but kind of tying that together and really understanding the natural history is kind of complex. So we don't have that kind of understanding, and kind of looking at this, it's not really a heterogeneous group, or this is not a homogeneous group, but more of a heterogeneous group. You know, it's really hard to pinpoint if there's really a genotype-phenotype correlation, or are there other genetic modifiers that may make the disease present worse, the phenotype worse in one individual compared to another. And if even therapy, if there's kind of genetic modifiers that make therapy more effective in some individuals than others. And then the last limitation I would say was this was funded by the pharmaceutical company, so kind of take everything as much as you can with the evidence that is provided. And just briefly looking at future directions, I kind of briefly talked about this, but they didn't go too much into if this reduced hospital admissions. I think that's something to really look at, if this is not only therapeutic, but also economically resourceful therapy. And then also looking at this therapy versus liver transplant. I briefly looked at liver transplant and kind of compared it to this, but I didn't really take the whole cohort. And I think that's something that can really kind of be used to compare those individuals. And then looking at therapy both pre-symptomatically and later therapies. Is this drug good for therapy early on before symptoms develop, or is this better used when you start seeing symptoms? That's something that should kind of we should think about for the future. And then finally, kind of thinking about, do we use this medication, do we use this therapy during acute crises? It did lead to hyperemic episodes, but can it be used during a hyperemic episode? I don't know if there's enough evidence really to say anything like that for those. And lastly, I just wanted to thank very briefly my program directors, Dr. Jai Ganesh and Dr. LaPiccolo, for their mentorship. So that's all I have. I don't know if there's any questions.
Thank you so much, Neil. It's an interesting study. I think we could take some questions now. All right, I guess if we don't have.
I do. Neil, nice presentation. But I also want to thank you and for taking the first general club and the slots to present. So is this trial collecting CSF arginase level?
No, they were not. They were not. I think that's kind of hard to really do, but I think that would be a great study to look at, to really see if it has any effect on the central nervous system.
Yeah. Hi.
And also, go ahead.
Oh.
Dr. Sanchez and also part of this trial PI.
I'm sorry that I have a cold, but that was wonderful. That was a great presentation, Neil. Thank you for taking that on. I think that you definitely talked about the things that are the reason why I think the drug is yet not FDA approved, and it's because sometimes correlating some of the biochemical outcomes is hard within if they improve or not the motor skills, and or if this is a progressive condition, are we really just halting the disease where it is and maybe providing respite for the patients long term. And I think that's the part that is very hard to prove. I follow around 6 kids with Arginase 1 deficiency. They are all Hispanics. They don't have the same genotypes, even though they are Central and South American. And so doing a genotype-phenotype correlation, I find very difficult too. I've done Arginase enzymes on several patients, and that doesn't correlate very well either. I have found it very, very difficult now that they're all off drug to control the arginine levels. And one of the things that we don't take into account is that when they get very sick, the arginine can go 7 times the baseline. And at that point, I don't know if there's additional damage from the guanidino compounds too, which we know to be epileptogenic and maybe be related to some of the other CNS manifestations. So CSF we don't have for this trial and for many of our just clinical patients either.
Yeah, thank you so much for your comments. Yeah, I mean, it is frustrating that we have, so much data, but then we can't really tie it enough to really get FDA approval. And I know it's approved in Europe, but it's not approved here. And I think it's, I appreciate all your work that you did on this. So.
And another interesting thing is I took care of patients with Arginase deficiency a long time ago. And so he has a very frequent and hypermanemia episodes and to admit. And so we were one time and we ordered a plasma amino acid as a part of the follow-up. And so the hospital ordered urine amino acid. And then turned out, and this patient also has cystinuria. And so those and the ornithine, cysteine, arginine was secreted from the urine. And so make the ornithine really low. And so you basically created more substrate deficit for the urea cycle, many hypermanemia episodes. So this means and there may be some modifier components and we don't know for every patient, and it's hard to get a unifying data. Yeah.
Yeah.
Very nice.
Yeah. Thank you. Thank you.
All right. Thank you. And now we move to the next speaker.
Yeah, we're excited to present Paige Souder. She's a combined pediatrics and medical genetic resident at Children's Hospital of Colorado. And she's presenting another interesting article, mitochondrial donation and pre-implantation genetic testing for mitochondrial diseases. So go ahead, Paige.
All right, thanks. I'll go ahead and share my screen. Yeah. There we go. Okay, can you all see the presentation now?
Yes, that's
great. So like she said on Paige, I'm actually the MBG fellow over at Children's Colorado now. They let me stick around for another year. But like she said, I'm talking about kind of reproductive options in mitochondrial disease, which is a very exciting, new development in the field. And then I have a QR code for the PDF for the paper here, if anyone wants to snap a picture of that. So just as an overview, like many of us know, pathogenic variants in mitochondrial DNA or mtDNA are exclusively maternally inherited and can cause a very wide range of clinical symptoms, including in many cases severe multi-system involvement that has significant morbidity and mortality. Currently in the United States, there's really not any reproductive options to prevent the transmission of the pathogenic mtDNA variants, but there is a relatively new reproductive care pathway in the UK that offers informed reproductive choices for women with pathogenic mtDNA variants via 2 different modalities, so mitochondrial donation or pre-implantation genetic testing. And I'll talk about kind of both of those different modalities in the paper today. And there's been some very optimistic results that we'll talk about too, resulting in multiple live births with substantially reduced or even absent heteroplasmy detected postnatally in those births. So very exciting stuff. And just kind of talking about something I'm sure we all know very well too, the familial burden of mitochondrial disease. So with transmission, there is a lot of variability in the level of heteroplasmy between different children, and it's often unpredictable, and that's largely due to the mitochondrial bottleneck effect. There's also unpredictable clinical expressivity among patients that can be partially explained, at least by tissue-specific distribution of the heteroplasmy. So all of this leads to very complex genetic counseling. And like I talked about, especially in the US, there's really very limited reproductive options to help prevent the transmission of disease. And this is specifically important in cases of higher maternal heteroplasmy, where there's a very high risk of having a clinically affected offspring. So just looking at the mitochondrial bottleneck effect a little bit more, if we look at a primordial germ cell here, this one has 50% heteroplasmy, so you can see the normal and mutant mitochondria and then the nucleus there. So these mitochondria are kind of randomly distributed into the primary oocytes without any replication. So you can have some cells at the top that get mostly normal mitochondria and others like the one at the bottom that gets mostly mutant cells. And then these mitochondria replicate to form the mature oocytes where you can see in the oocytes that had a higher percentage of mutant mitochondria, and those are more likely to be severely affected with replication of those mutant mitochondria. So that kind of explains how you can get such a kind of variable distribution in kids. So like I said, the two kind of different modalities are the mitochondrial donation pre-implantation genetic testing. So we'll talk about PGT first. So just kind of in general, the goal for this is to select for genetically favorable embryos prior to transfer into the uterus in specific clinical scenarios. There's three main modalities that exist currently in the US, and this is one is for monogenic disorders or PGT-M, another for aneuploidy, PGT-A, and then one for structural rearrangements or PGT-SR. And kind of the general principles are to use a few cells from the early embryo, which typically is from the tropoectoderm, or the cells that will go on to become the placenta. And this is really best established for monogenic disorders and structural rearrangements. But still is considered a screening test. So confirmation with either CVS or immunocentesis should also always be offered with this. And kind of looking a little bit more at these. So PGT-M, you're testing for a specific known pathogenic variant in the family, usually via linkage analysis, so require samples from multiple family members. You can't detect de novo variants with this because of the linkage analysis. And it's possible, but really rare to have a misdiagnosis just because of the specificity of the testing. With PGT-A, you're looking at all the chromosomes, including X and Y, but misdiagnosis is more common because you can have placental mosaicism that won't necessarily match the genetic content of the cells that will go on to become the embryo. And then for the structural rearrangements, you can't differentiate between a normal karyotype or balanced rearrangement. And then you also have risk for rearrangements involving imprinted genes. So that's a consideration with those. And then some of the more investigational methods are non-invasive PGT, which is being looked at in some other studies, and then PGT for mitochondrial disorders, which we'll talk about today. And for mitochondrial disorders specifically, this really doesn't work for variants that are at a high heteroplasmy or homoplasmy, and that's just because of the really low chance of having an embryo that would have a low enough heteroplasmy to justify transfer. So for those patients, pronuclear transfer or mitochondrial donation is an option. And this involves transfer of a pronuclei from a fertilized zygote that has the maternal and paternal haploid genomes, and transferring that into a donor egg that has normal mitochondrial DNA. So you do have some carryover maternal DNA just from the cytoplasm around the pronuclei when you do that. And then cell lines, they've shown that this increases to become homoplasmic in a decent percentage of those, but the carryover is overall pretty small. And there's actually a cool video here, so I'll play that for a second, of the actual process of removing the pronuclei and then transferring it in. So you can see the kind of the two little circles there are the pronuclei. So this is the probe that's going in to extract those and taking them out very carefully and slowly, but you can see how some of the cytoplasm does go along with that. But basically, they'll take both of these pronuclei, take them out, and then also remove them from the donor egg, like you'll see here, or this is the second nucleus, and then they'll actually insert those into the enucleated donor egg. Let me see if I can get to that part in the video. Yeah, so here's, I think, the enucleated egg. Well, they'll put that pronuclei back in. So looking at this study specifically, to recruit patients for this, they all underwent health and fertility assessments prior to retrievals. And then the donor DNA was also screened for pathogenic mitochondrial DNA variants to make sure there's not an undiagnosed donor that we're looking at. All families were offered extensive counseling, both before entering the program and then throughout treatment. And then in terms of the patient population, the distribution of pathogenic variants was included both protein coding and mitochondrial tRNA genes. The MT and D genes were most common, especially the MT and D1 for Leber hereditary optic neuropathy. And then NT8-ATP6 was the most common protein coding. And then the M.3243 variant in MELAS was the most common tRNA variant that was seen. And 12 patients were homoplasmic and 48 were heteroplasmic. One had a large-scale mitochondrial DNA deletion. And then out of these, 13 were offered pronuclear transfer based on either homoplasmy or a very high level of heteroplasmy. And out of those, almost half were LHON, and then 5 had the 3243 variant. So specific methods for the pronuclear transfer, the patient oocytes were all frozen, so there was a fresh donor egg that was available. And then they were all fertilized with intracytoplasmic sperm injection, where you inject a single sperm directly into the egg. And then they did the pronuclear transfer at the 5 or 6 day stage in the blastocyst. And either partner or donor sperm was used. And in the cases where donor sperm was used, that was because the partner was actually related to the egg donor. And then for PGT, the methods was a little different than the typical PGT regimen that I talked about before. So instead of using a trophoblast, there was actually a single blastomer cell that was removed on day 3, and then that was analyzed for heteroplasmy. And then culture was continued after that for 2 or 3 days to get to the blastocyst stage. And then embryos that were of suitable quality and had less than 30% heteroplasmy were selected for transfer. And this is just a snapshot of the reproductive care pathway in a little bit more detail. So you can see kind of the criteria, included age and kind of general health things. There were a couple people that didn't initially meet criteria based on the health assessment, but were able to have an intervention that was largely weight loss, and then did become eligible for the study. And then you can see kind of the separation between choosing either the PGT pathway or the pronuclear transfer pathway here. And there ended up being 13 live births with the PGT pathway and 8 live births with the PNT pathway. And this is kind of just showing that, again, with the actual embryo transfer. So looking at the outcomes from an IVF standpoint, if we compare the 3 groups of the pronuclear transfer, the PGT, and then the donor, there was a similar number of oocytes or eggs that were retrieved, and patients underwent anywhere from 1 to 3 cycles for oocyte retrieval. And then also a similar proportion of those oocytes were mature among the groups. There was a lower percentage of normal fertilization that was observed in the patients that were undergoing pronuclear transfer, and this did seem to correlate with specific mitochondrial variants. So the LHON 3460 variants, the MELAS 3243, and then MARF8344, and then also rare mitochondrial tRNA variants, which they defined as having homoplasmy for a tRNA variant, was also kind of overrepresented in those groups, specifically had lower fertilization rates. And you can see that in the data here. And then just comparing PNT versus PGT. So this is a figure going through kind of the pronuclear transfer process. You can see the donor and the patient, both eggs are fertilized and get to the pronuclei stage. The donor karyoplast or pronuclei are discarded and then replaced with the patient pronuclei. And it's showing you kind of the orange, like a little bit of the mitochondrial transfer from the maternal egg, but you have mostly normal mitochondria from the donor. And then they did assign semi-quantitative scores to look at that a little bit closer. Most of them were pretty low. And then there was a pretty high success rates for that procedure, so almost 80% that had successful transfer of the pronuclei. And then looking at kind of the quality, you can see in figure 3D here, examples of top and good quality. I think fine quality was also acceptable for transfer. This is actually a little bit lower in the PGT group compared to the PNT. And then they did note too that in the PGT group specifically, a decent percentage of those had greater than 30% heteroplasmy, so weren't deemed suitable for transfer, even though they were good quality. So that's definitely a consideration with PGT. And then looking at clinical outcomes, around 80% of patients in the study did end up with embryos that were available for transfer, and 40% ended up with a clinical pregnancy. There was a lower percentage of that in the PNT transfers and also an increased rate of pregnancy loss. But 3 out of these 6 patients did go on to have a subsequent clinical pregnancy after a loss. So that suggests that it's not something with the specific combination of maternal and donor DNA or like an intrinsic maternal factor that caused that, but kind of an unclear reason at this time. And then there were a couple of the pregnancies with PGT that ended in miscarriage, but none of the 8 pregnancies that went on for the PNT ended in miscarriage. And then out of the 8 live births that were observed, over half of those were with the Elhan variant, and then 3 were with the rare tRNA variants. There were no patients with the 3243 MELAS or the 8344 MARF variants that went on to have a live birth. And then interestingly, there was 1 pair of monozygotic twins from a split embryo. And then in PGT, that resulted in 18 live births. Out of the infants, they were all born at similar gestational ages, had appropriate birth weights, and no congenital anomalies were observed. And then looking at postnatal heteroplasmy, this was significantly reduced compared to maternal levels in neonatal blood for both groups, so the PNT and the PGT. And the PNT, there were some that had undetectable heteroplasmy, a couple that had relatively higher, one at 12% and one at 16%. But that was, again, compared to very high levels of heteroplasmy in the patient egg that was used in the maternal blood. And then for the PGT group, heteroplasmy ranged from 0 to 7%, and that's compared to anywhere from 23 to 61% that was detected in the maternal urine. And then they also looked at embryos for PNT that were not suitable for transfer, and those had a low heteroplasmy as well, anywhere from 0 to 4%. So showing good efficacy there. And then for the 2 infants that had the relatively higher heteroplasmy at 12 and 16%, there wasn't any difference in the carryover score, so that wasn't thought to be due to like an increased amount of maternal cytoplasm that got in there. They hypothesized that this might be a replicative advantage of the patient versus the donor mitochondrial DNA, but kind of unclear. But those are like relatively higher, but still very low and not expected to cause significant disease. And then, 70% of the patients who underwent the pronuclear transfer did not end up having any zygotes that would have been suitable for PGT. So they all had over 30% heteroplasmy. So again, just kind of some evidence that PNT needs to be offered as an alternative for those patients to PGT. And then there was a kind of companion paper that came out in the New England Journal of Medicine along with this that looked more closely at the 8 live births after the pronuclear transfer. So these patients, the infants were generally healthy. There was one baby that had hyperlipidemia in Wolff Parkinson White, and that was in the setting of maternal hyperlipidemia during pregnancy. And that was a mom with the M.4300 variant, and the postnatal heteroplasmy in that baby was 5%. And that child remains on medication for Wolff Parkinson White, but hyperlipidemia has resolved and does not have any other significant health issues. And then there was also one child that had myoclonic epilepsy that was detected in infancy that spontaneously resolved without treatment, and they have not had recurrence of seizures. And that child actually had a 0% heteroplasmy detected postnatally, or non-detected heteroplasmy. And then just looking at all the other children in general, they were anywhere from 0 to 24 months of age at the time of this paper, and they all had normal developmental progress, which is very reassuring. And here's a couple of tables from that paper, just going into more detail about the characteristics of both the women and the pregnancies and infants. So you can see like pretty high levels of heteroplasmy or homoplasmy in the moms to begin with, and associated with significant disease, including blindness and cardiomyopathy. And then looking at the pregnancies, all pretty normal gestational ages. There were a couple that were late preterm, including the set of twins, and then one that was a post-term pregnancy. So those babies had a slightly lower initial APGAR score, but then all of those had higher APGAR scores at 5 and 10 minutes. And then significantly lower heteroplasmy in the neonates that you can see there postnatally. The other thing that I noted is a high rate of cesarean delivery, and I wonder if that's just kind of a product of IVF rather than the pronuclear transfer itself. So some conclusions for this paper and just points for discussion. So I think this does provide good evidence that both PNT and PGT are effective risk reduction strategies for people with pathogenic mitochondrial variants. And the authors did emphasize that just because of the new technology, that this should be kind of built as a risk reduction rather than a curative therapy. But I think, important things to look at going forward will be ethical and legal considerations with this, which is, I think, a big reason why this is not available in the US right now. And then looking at more long-term follow-up, including like potentially changing heteroplasmy levels as these kids get older and any other health issues that come up. And just also, this is IVF in general is a very costly procedure, and genetic testing for IVF is even more. So making sure that this is a covered benefit with insurances and that it's equally available for patients regardless of socioeconomic status or location. So that is all that I have. So I'll open it up for questions or comments or other discussion now.
Hi, Paige. Thanks for taking this on and presenting that. I did have a question that may or may not, you may or may not know. So it is interesting. I personally always get worried with the more that we, for lack of a better word, futz around with these embryos. Of how much manipulation and things that we're doing. It always worries me. And I think that if we don't look far enough out, we're going to miss things. And so in these kiddos, and I get that we're doing the heteroplasmy. I'm assuming, by the way, the heteroplasmy on the infants once they were born was on, or the testing was on blood only, or did they do 2 cell lines?
You see, they did blood and urine. Yep.
Okay. So no fibroblasts though.
No fibroblasts.
Okay. Just always a point of discussion, right? How many lines do you take? But the other question I have is that this was 2 years out. Did they talk about anything about doing further out? Because a lot of these conditions in general, we don't, especially with the lower levels of heteroplasmy, we don't always see the symptoms until later anyway. And so what is their plan for follow-up? And how do you follow these kids? Just long term.
Yeah, that's a good question. I don't know like a lot of the specifics about their follow-up plan. I do know they have a plan to follow these children like later on, and they're planning to publish another study once they have, more of these children that are born and getting older. But yeah, I do think it's going to be really important to, see if any of these, like I said, like if heteroplasmy is changing over time, like if there's a advantage of the maternal mitochondria that did, get transferred. And that carryover. And then if they develop any kind of health conditions, whether it's related to the mitochondrial disease or kind of a side effect of the whole process and futzing around with the embryos, like you said. And I think something to note too is in the PGT group, with the difference in how they collected the cells, like they're actually collecting from the blastomere, so the embryonic cell mass, rather than the trophoblast. And I think that is potentially a reason why there were lower quality embryos in that group. And they talked a little bit in the paper about, changing that to do the sample on the trophoectodermal cells instead of the nuclear cell, but there can be some discrepancy in heteroplasmy there, so that's why they're not doing it that way right now.
Thank you.
But very good thoughts and comments. Thanks.
It's just amazing work. So I was wondering the coordination of all this done in the short period of time is really challenging. So they also mentioned the donor egg, and they have to sequence the mitochondrial like a sequence. So how long it takes to make sure that's in the fresh, and yeah, it was amazing work.
Yeah. Yeah, I know. Like for the PGT, I mean, they're sequencing that mitochondrial DNA in 3 days because they're using fresh transfers for that. So that is another reason for testing it at the, the 3-day point instead of the 5-day. So I imagine the turnaround for that is pretty quick, which is pretty amazing.
Any other questions? Yeah, I think if this we learn more about this, and yeah, definitely bring options for the patients with mitochondrial condition. I think it's very important to notice that this is a risk reduction, not a cure, even though went through all these challenges. Yeah. Dr. Baker, you have anything comment?
No, I was just gonna echo what's been said already. I mean, you've got your mitochondrial bottleneck in oogenesis, and you sort of bypass that, but then you've got independent segregation of mitochondria in the tissue at a really early stage. So who's to say that the muscle heteroplasmy is not already, not even changing over time, but already higher in the neonate? You're not checking that. So I do think long-term follow-up is really important. And scheduled echocardiograms or I don't know what else you could really do that's not invasive, but yeah, it'll be interesting to see if they have a follow-up to this.
All right. So if no question, we can conclude this session. And thank you again for Neil and Paige take the initiative. So I'm looking forward and for the future. First Friday and noontime. Yeah, welcome to join November 7. 2 fellows from Baylor are gonna present at the next journal club. Thank you.
And Hong, just a note, I did put in the chat that our abstracts are open for the 2026 annual meeting at SIMD. So I will post that again if anybody wants the link again.
Yeah.
Thank you all.
Thank you. Have a good weekend. Bye.